First thing, very importantly, after listening to the history, what you should come to a conclusion is determine whether the patient is having a specific set of symptoms which classically defines a condition. For example, if the patient says, I have paucity in movement, I'm not able to shout louder, I'm not able to walk faster, slowly my movements are coming down, classically you can see that Parkinsonism, and you can have one single hypothesis that it is a Parkinsonism. Your hypothesis is very simple and direct, no problem. But in case if you have the patient coming out with numerous issues, symptoms, the problems are, the patient says, I'm unable to lift this hand, I have pain here, I have nocturnal urea, all these things. If the patient is coming up, then your hypothesis is going to be very tough for you. And in my experience, if the patient is very precise with their chief complaints, then they have a major problem. But when the patient is not precise with their chief complaints and they are just spraying out information, then the problem may not be a big problem. Okay, so this is out of my experience I am saying, because patients who are coming with CVA will have one or two chief complaints only, but they have major functional limitations. But patients who are coming with some neurological pain related problems will have many complaints, but their problem may not be actually that big. So that is my experience. Next is you have to identify a specific pattern in all the chief complaints the patient is giving. So the second scenario becomes very tough. Okay, and now once you form a hypothesis, you can have one or more hypotheses. It should be in an order, very importantly, because the most I suspect this patient to be a Parkinson patient. Okay, I also suspect this patient to have a supranuclear palsy, because he's complaining of a sudden onset of all these symptoms. Supranuclear palsy, mind you, is more or less like Parkinsonism, but it's a vascular disorder. Here, dopamine is not a problem. It is a vascular disorder which affects a superior nucleus, which results in classical symptoms of Parkinsonism. Okay, but one or two things will be missing, but this is also a condition. So I suspect this patient to be 70% Parkinson. So first hypothesis is Parkinson, but he may be a supranuclear palsy also. So PSP will be second. So that order you should maintain. Should be at impairment level or activity level. That is the very important thing. Impairment level means some anatomical structure should be involved, anatomical function should be involved. So more you go specific, you can go with the impairment level. Very rarely you can give activity level hypothesis. So when I say impairment, if my axillary nerve is affected, that is my impairment, because of which the biceps, the deltoid goes for weakness, that is impairment. Because of that, what I'm not able to do, I'm not able to elevate my hand, that is activity. Because I'm not able to lift my hand, what I'm not able to do in my day-to-day activities, I'm not able to pluck flowers, I'm not able to keep objects on the top, I'm not able to do my functional, I'm not able to comb hair. So your hypothesis should be mostly impairment level, and